Good morning, everyone. Today's seminar is on EEG beyond epilepsy in metabolic, toxic encephalitis, neurodegenerative, and neurodevelopmental disorders. Brief about the history of EEG, as everybody knows. It was in 1924 that Hans Berger first recorded EEG. He first aimed to find physiological correlates of normal mental activity, and he used it as a tool to study normal cerebral physiology and founded alpha. It was in 1930s that EEG utility in epilepsy diagnosis was put forward by Frederick and Erna Gibbs and William Lennox. And later in 1936, Walter demonstrated utility of EEG in encephalopathies as well as altered consciousness. It was Foley in 1950 who found diffuse slowing and triphasics in metabolic and toxic disorders. In 1980s and 90s, quantitative EEG and event-related potentials were discovered and started to be used in cognitive neurology and psychiatry. And 2000s and beyond, continuous EEG monitoring helped to find out NCAC as well as EEG in comatose patients and helped in prognostic roles. In present era, there are these EEG extends to brain-computer interfaces and helps in neurofeedback and consciousness studies, as well as it is used as a universal tool for brain function assessment. Just an introduction about EEG in encephalopathy. In 1988, SINET has classified EEG in encephalopathy based on and classified as following grades. Grade 1, dominant alpha activity with some scattered theta activity. Grade 2, dominant theta activity, generally reactive. Grade 3, dominant widespread delta activity with or small amplitude diffuse irregular delta activity, usually non-reactive. Grade 4, characterized by burst suppression pattern and epileptiform discharges, low output activity and is non-reactive and can have alpha comma pattern and theta comma pattern in grade 4 and grade 5 isoelectric activity. Grade 1 and reactive grade 2 was mild stages of encephalopathy. Grade 3 and 4 are moderate to severe ones and 4 and 5 are very severe ones. And in characteristic, different encephalopathies can have different characteristic EEG frequencies. Alpha frequencies are usually seen in mild encephalopathy reversible conditions, like elderly with urinary tract infection, as well as metabolic encephalopathies. Beta can be seen in toxic encephalopathies, agitation, anxiety, benzodiazepines, barbiturates in withdrawal states. Theta in dementias and moderate encephalopathies and systemic infections. And delta in severe encephalopathies and with increased intracranial pressure as well as marked white matter dysfunction. Coming to reactivities. Pathological alpha can be differentiated from normal background alpha by reactivity, presence of reactivity. Coming to EEG in metabolic encephalopathy. Metabolic encephalopathy, as we all know, is a brain condition where caused by severe organ failures, electrolyte abnormalities, endocrine, nutritional, toxic, as well as systemic causes, and which finally leads on to neurotransmitter dysfunction in the brain and involve a dysfunction of ascending reticular activation system. What is the role of EEG in metabolic encephalopathy? EEG is a readily available, relatively cheap and mostly used method for assessment in the case of a patient with altered sensorium or reduced consciousness. And it can help differentiate an organic from psychiatric cause. And in a patient with altered consciousness, it can diagnose NCAC, as well as it can determine the severity of underlying brain dysfunction and predict clinical outcome based on encephalopathy gradings that I've already described. And we can also assess therapeutic response or deterioration by periodic EEGs. So in metabolic encephalopathies, various patterns have been described. Most commonly slow patterns like generalized slowing, generalized theta activity, generalized high voltage delta activity, rhythmic delta activity can be seen. But earliest sign in majority are slowing of the alpha background alpha rhythm. And frontal intermittent rhythmic delta activity has also been characterized in various toxic and metabolic causes. Where an asymmetric FIRIDA if patient is having, it can suggest a focal pathology and we need to look for focal causes. Occasionally, FIRIDA can occur during hyperventilation and during drowsiness also in normal subjects. Triphasic waves are an important category of transients that are seen in metabolic encephalopathy. And the new terminology is generalized periodic discharges of triphasic morphology according to ACNS guidelines. And these are surface positive high amplitude more than 70 microvolt waves preceded and followed by negative waves of smaller amplitude, which is the typical triphasic wave. And the pathophysiology is due to dysfunction of the thalamocortical relay neurons. So the thalamocortical projections have various fires at various rates. So it can present with anteroposterior or posteroanterior delays. And the types of triphasic waves has been described. The classical ones in sepsis as well as hepatic uremic metabolic encephalopathy are the typical triphasic waves, where it is well-formed, smooth contoured, negative, positive, negative in polarity, and in phases, and bilateral, symmetrical, and synchronous, regular, and reactive ones coming in a frequency periodic fashion at 1.5 to 2 hertz frequency on an average, and they can have frontocentral or fronto-occipital lag. Usually frontocentral in location and can have a fronto-occipital lag. Whereas atypical triphasic waves are usually or the frontopolar or parieto-occipital region maximum it will be present. It can have negative positive or negative positive negative phases, and it is usually asymmetric, asynchronous, unreactive, irregular, multifocal, continuous, and can have spatiotemporal evolution. And they are usually sharper compared to typical triphasic waves, which are smoother. And this atypical triphasic waves are seen in Angelman syndrome, toxic encephalopathies, hypothyroidism, Hashimoto's encephalopathy, NCSC, dementia, sepsis-related encephalopathy, and cerebrovascular disorders. So this is a triphasic waves in the case of hepatic encephalopathy. You can see typical triphasic waves. So this is an EEG in longitudinal bipolar montage that is read in a sensitivity of 10 microvolt. You can see background slowing, that is generalized slowing, and there is generalized periodic discharges of triphasic morphology that are present bilaterally and mostly expressed in the frontocentral regions. And you can see three phases: initial negative, then a positive, and then negative phase. This is the same shown in average montage. There is a fronto-occipital lag, that is from frontal to occipital regions, there is a lag. The leading frontal sharp wave precedes the occipital ones. So there is a fronto-occipital lag demonstrated. So hyponatremia, coming to hyponatremia, CNS manifestations and EEG changes in hyponatremia are based on rapidity in fall of serum sodium. And it is seen in increased incidence in people who are already on carbamazepine and oxcarbazepine. And even after correction of hyponatremia, EEG may take time to become normal. And this is EEG findings that are described in hyponatremia according to Fagel et al. Given. And all findings like background slowing, increased theta or delta activity, FRIDA, periodic lateralized epileptiform discharges, triphasic waves, and NCSC have been reported in cases of hyponatremia. Coming to a case, a 63-year-old female presented with 2-week history of fever and malaise, with decreased food intake followed by delirium. On examination, patient was awake and disoriented with a serum sodium level of 130 milliequivalents per liter, potassium of 4.6, serum creatinine levels of 1.3. Blood routine and TFT was normal, and CT brain was showing cerebral atrophy. So this was the EEG read in the longitudinal bipolar montage with a sensitivity of 7 microvolts per minute. You can see frontal, intermittent, rhythmic delta activity, that is frontal predominant and bilaterally seen. And so this is a case of FRIDA in hyponatremia. react, sort of, there is overall, no, yes, sir, yes, sir. There is eye movement and attenuation also. Yes.
The second and third second finding the event that can be called as the vertical.
Their attenuation is not
It's basically monomorphic conflict and which is having a
field.
response.
Field is having fields front of center. Going to hypocalcemia. Hypocalcemia is the most epileptogenic metabolic disturbance, and up to 70% cases can have seizure, and rate of fall of calcium is more problematic. And EEG changes described include diffuse background slowing with paroxysmal theta delta activity, and there are focal or generalized spike and spike wave discharges, which can get increased by hyperventilation, and that is seen. And there can be NCSC as well. So coming to a case, a 32-year-old female with normal birth and development underwent thyroidectomy for papillary carcinoma thyroid 9 years ago. And she presented with recurrent episodes of paroxysmal events from May 2018, which were not stereotyped. She had a feeling of generalized stiffening of body, head turning to one side, but there was retained awareness and fall from bed from one occasion. She was on carbamazepine 400 mg per day for the same, but even with treatment, she had continued episodes. On examination, was conscious, oriented, had no focal deficits, and CT brain shows specks of hyperintensity in bilateral basal ganglia. This was the EEG of the patient in red in bipolar, longitudinal bipolar montage with sensitivity of 10 microvolts per minute. Here also you can see rhythmic delta activity in frontal region, predominantly in the frontal region with a field. This is also intermittent frontal intermittent rhythmic delta activity in a case of hypocalcemia. In addition, there are occipital sharp transients as well in posterior. The frontal, yes. Yes, occipital.
Right. Where usually that
So this delta activity was preceded by occipital sharps, and the intermittent delta activity was succeeded by alpha rhythm as well. So this can suggest it can be due to hypocalcemia and metabolic encephalopathy. The same read in average. In the serum calcium levels in patient was 4.2. With serum albumin was normal, and serum inorganic phosphorus was 5.4, and EEG changes were supposed to be secondary to hypocalcemia. Hypercalcemia, hypercalcemia actually causes CNS depression and reduced neuronal membrane excitability. So seizures are rare in hypercalcemia, and very rarely occipital, parieto-occipital regions can show some epileptiform activities, and EEG changes appear only when serum calcium levels are more than 12 milligram per deciliter. Coming to endocrine disorders like hypoglycemia, EEG changes at blood sugar less than 70 milligram per deciliter. There can be generalized predominant frontal theta delta activity with spike and sharp waves, lateralized periodic discharges, and hypoglycemia due to insulinoma can mimic various seizure types and epilepsy syndromes. So coming to the case, 18-year-old, this is a case of 18-year-old male with born out of non-consanguineous parentage with normal birth and development, with habitual seizures since 10 years of age, with head aversion to one side and drooling of saliva followed by generalization at 1 to 2 per month frequency, initially which increased to daily episodes with episodic cluster. On examination, was conscious and alert with no focal neurological deficits. So this was the EEG during the event. Patient had this EEG read in bipolar montage with a sensitivity of 10 millivolts, and the EEG showed a generalized delta attenuation, and rather than epileptiform activity. This was the EEG read in average montage. Further, during the event, patient had an RBS of 41. Electrolytes, RFT, and LFT was normal. Serum insulin was at the higher normal rate, and C-peptide levels were high. And CCT abdomen showed an ill-defined lesion in the tail of pancreas with tracer uptake, showing suggestive of insulin. Coming to hepatic encephalopathy, EEG changes in hepatic encephalopathy has been described in various stages based on various rhythms. There is normal EEG with normal background. This is normal EEG with normal background. In grade 1 EEG, this alpha frequencies may be more anteriorly frontalized alpha may be seen with intermixed theta rhythm. In grade 2, there can be predominant theta frequencies with intermittent delta. In grade 3, there can be generalized delta rhythms with transients occurring like the generalized periodic discharges of triphasic morphology or other transients like sharps and spikes. And deep coma may show generalized delta activity or attenuation. And here they have demonstrated a gasping artifact of the patient. So this is a case of 62-year-old male with the comorbidities like diabetes mellitus for 27 years on insulin and CLD with portal hypertension. Present with irrelevant talking intermittently with decreased food intake and needed to be coaxed for basic needs and generalized tiredness. And on examination, his vitals were normal. GRBS was 206, was drowsy and responding to commands, had flapping tremor and bilateral pedal edema, had minimally elevated bilirubin of 3.1 and reduced albumin levels of 2.8, and plasma ammonia levels were high, 274. This was the EEG read in bipolar montage. You can see at a sensitivity of 7 microvolts, the moderate amplitude, generalized periodic discharges, bilateral periodic discharges. Bilateral periodic discharges of triphasic morphology. So we can see typical triphasic morphology with lag. Toronto Hospital. Occipital region and hospital.
The state at which EEG was taken was taking the patient was completely conscious. The patient was probably.
Patient was in drowsy states. The same in average montage. Coming to uremic encephalopathy, uremic encephalopathy can show progressive slowing of the background rhythm based on the severity of uremic encephalopathy. And in approximately 20% of cases, they can show triphasic waves. And seizures and epileptiform activity are more common in uremic rather than hepatic encephalopathy. And EEG is best correlated with the blood urea nitrogen levels and based on progressive worsening. And dialysis encephalopathy can also have EEG changes like high voltage delta activity that is maximum anteriorly expressed. And this is a case of 67-year-old male who's diabetic for 20 years and CKD on hemodialysis with altered sensorium for 1 day. And his GCS was E3V1M5. Upon admission, had 1 GTCS was started on tab eptoin. His serum creatinine levels were 12.7. So sodium is 134, potassium levels 5.8. And imaging, basic CT brain was normal. This EEG is read in bipolar bondage and sensitivity of 7 microvolts. You can see bilateral slow waves bilaterally seen in the left more than right hemispheres. And there are intermittent triphasic waves, occasional triphasic waves coming, predominantly expressed in the frontocentral regions. State of the patient is, GCS was E3V1M5 and drowsy patient.
What is
Sleep spinals, yeah. Probably sleep.
updates which appear to be not appear to be in physiological state patterns.
Yes,
The bilateral
frontal regions.
start getting the specific pattern of as of now. Just showing some not here. Bilateral sharp glasses. Start the typical
Typical triphasics. This triphasic morphology kind of sharp transients coming occasionally in the frontal regions with probably patient is in sleep due to. Encephalopathy can get photosensitivity. Patients with uremic encephalopathy can get photosensitivity, photomyogenic responses. Other endocrine disturbances, hyperglycemia can, the EEG can be normal up to a level of 400 milligrams per deciliter, and focal predominant spikes can be seen more than 400 milligrams per deciliter. And lateral periodic discharges usually needs, if the hyperglycemia has lateral periodic discharges, if lateralized periodic discharges usually needs a structural lesion. But whenever a patient is having a hyperglycemia or a stroke patient is presenting with altered sensorium, we should suspect hyperglycemia if there are lateralized periodic discharges. And seizures are usually focal in hyperglycemia when compared to hypoglycemia, which is usually generalized. And NCSE is can also occur in non-ketotic hyperglycemic to ketotic ones. Hyperthyroidism can also have increased frequency, increased background frequency, increased sensitivity in the EEG, and there can be higher incidence of theta and delta activity also. Summarizing findings, EEG findings in endocrine disturbances, non-convulsive status can be seen in hyperthyroidism, hyperglycemia, hypoglycemia, hyponatremia, as well as hypocalcemia. Epileptiform abnormalities can happen in almost every cases except hypothyroidism. And triphasic waves can be seen in hyperthyroidism, hypothyroidism, hypocortisolism, hyponatremia, hypercalcemia. Coming to EEG in toxic encephalopathy. Toxic encephalopathy can develop can develop after exposure to normal medications that patient use, or exposure to toxins like toluene, organic solvents, heavy metals, medications like methotrexate, baclofen, cyclophosphamide, natalizumab, melarsoprol, etc. With benzodiazepines, there can be increased beta activity, decrease in alpha frequency, and at toxic levels can show marked slow activity. Barbiturates can present with rhythmic fast activity and frontal dominant fast activity with delta activity with superimposed spindle-like activity in burst suppression in the deep toxic stage. Lithium can show typical periodic triphasic waves. This is a case of benzodiazepine-induced excessive beta activity. Recently, the emergence of frontal predominant beta activities. Patient is drowsy. No, no, sir. No, this is just a drug-induced beta. Drug-induced betas.
I think you speak that. Patient is not in the state of rest.
No, sir.
Yes, yes, and beta activity over.
Front fractures. Okay, sir. Okay, sir.
Just not problems, which is for diagnostic and how this patient had company with encephalopathy of unknown etiology, or your casualty, encephalopathy of unknown etiology, or pain of pain. So there's no prior history for patients or not on medications. And this comes to you. You
The
know,
mitochondria.
recreational drug use was suicidal attempt. This EEG which will support the diagnosis of smoking benzodiazepine. Oh, yeah. That's the supportive role of the EEG. It doesn't require to take the director investigations towards doing the urine for benzodiazepine and toxins and all those things. Yeah. This is not a pinpoint. You have to suspect. You need for ordering from you.
The CAR T-cell immunotherapy has been recently being increasingly used in cancer treatment. For the Society for Immunotherapy for Cancer recommends EEG. It has recommended EEG in all suspected cases of encephalopathy due to immune effector cell therapies. And they usually present with encephalopathy seizures and raised ICP features. And EEG can show diffuse slowing, occasional generalized periodic discharges, triphasic waves and sharp waves, or electrographic seizures if the condition is severe. This was a patient who developed EEG of an unconscious patient with CAR T-cell related encephalopathy syndrome following therapy for B-cell lymphoma. It showed the triphasic-like waves, frontally predominant, periodic waves coming. And this was followed by seizures and patient subsequently expired. This the non-convulsive status as well as seizures have been found in cephalosporin-induced toxicity as well. That is especially when used in renal insufficiency Cephalosporin can lead on to seizures as well as non-convulsive status. This was a case of 52-year-old patient with CKD who was treated with cefepime for Staphylococcus aureus UTI. On the second day, patient became delirious, and this was the EEG taken during that time. And this shows frontal predominant, more than 3 hertz frequency of spike in wave discharges. That is ellipticus. And this patient was treated with diazepam for this. And after which EEG, there was generalized theta and delta activity, which was seen after treatment with diazepam. Coming to EEG in autoimmune encephalitis. What is the role of EEG in autoimmune encephalitis? To characterize seizures, autoimmune encephalitis is marked by initial behavioral disturbances and initial seizures. To characterize the seizures, we can use EEG. To identify electrographic seizures as well as non-convulsive status epilepticus. And to look for localized slowing or in IEDs, which can point to region of dysfunction in autoimmune encephalitis, and to find out the etiology. And so frequent EEG findings include frequent seizures, subclinical seizures, NCSC, background slowing, focal abnormalities, and characteristic patterns in various types of encephalitis. Coming to the prototype, the anti-NMDA receptor encephalitis, which is the widely studied one. And EEG is abnormal in 90 to 100% cases of NMDA receptor encephalitis, according to studies. And epileptiform abnormalities, epileptiform abnormalities may be seen in 24 to 50% of the EEGs. And an abnormal EEG can correlate with an increased likelihood of admission to ICU and an incomplete recovery. In NMD encephalitis, MRI abnormalities may be seen in only 32% patients in the initial stages. And CSF analysis and antibody can become late or will be available only in the later date. So EEG during the initial presentation is potentially more useful in case of NMD and suspected NMD encephalitis. These are the EEG findings that are described. Delta slowing, extreme delta brush pattern, generalized rhythmic delta activity, diffuse beta activity, as well as epileptiform abnormalities, lateralized periodic discharges, generalized periodic discharges, and seizures and status epilepticus. So this is a case of a 25-year-old female presented with acute onset febrile illness, followed by prominent behavioral symptoms, focus seizures with perioral and limb dyskinesias. And on examination, her GCS was E2V1M4. She had perioral and left upper limb dyskinesias. Her serum anti-NMDA receptor antibody levels were 2+, and MRI brain showed mesial temporal lobe hyperdensities, and a diagnosis of NMDA encephalitis was made. This was the EEG read in bipolar montage with a sensitivity of 15 microvolts per millimeter. And you can see the frontal predominant delta, rhythmic delta activity that is superimposed by fast activity or beta activity over it. These are called extreme delta brushes. Similar, the same in the average montage. This is similar to neonatal EEG. This is a delta brush in neonatal EEG, where there is delta waves superimposed by fast activity. So delta brushes are already being described in neonatal EEGs. So this similar finding in NMDA was called delta brush. And this extreme delta brush is so this is the patient. This is patients. But this was a neonatal EEG. And this is probably an abnormal record, not demonstrating delta brush. The extreme delta brush is seen at a peak of disease severity. It may not be specific, but is a marker of severe encephalopathy. NMDA is crucial for network control and to sustain synchronized network dynamics. So, failure of NMDA network stabilization in NMDA receptor encephalitis can cause an imbalance of fast and slow activity and can cause beta and delta range abnormalities. So that is the basis of this delta brush in NMDA receptor encephalitis as well as delta and beta activity. In the early stages, patient can have excessive beta activity when with cortical dysfunction and increased there can be extreme delta brush. Later, when there is subcortical and basal ganglia dysfunction, patient can have generalized rhythmic delta activity. And that correlates with abnormal movements and dysautonomia. Coming to anti-GAD mediated encephalitis, it is a type of limbic encephalitis where temporal lobe epilepsy and neuropsychological deficits may be seen. And that it can be paraneoplastic or non-paraneoplastic. And common EEG findings that are demonstrated include intermittent rhythmic delta activity in bitemporal regions. Epileptiform spike and wave discharge is predominantly temporal, and patient can have temporal slowing as well. So, coming to a case, this is a 34-year-old male with normal birth and development with subacute onset memory difficulties in the form of forgetfulness in recent conversations, irritability, difficulty in identifying familiar peoples that is of 4 years duration. And he also had, at the onset of illness, 2 episodes of focal seizures with impaired awareness, with drooling of saliva. And he was diagnosed as a young onset diabetes mellitus 6 months after the onset of illness. On examination, his MMSE was 30/30, and he had on detailed lobe function an impaired story recall, mild verbal memory impairment, and he had high GAD65 antibody titer of 88 in this was his EEG read in bipolar at a sensitivity of 10 microvolts per minute. You can see the left in the left temporal region, there is slowing as well as rhythmic delta activity coming. There is a left temporal slowing. Post sharp transients and in the temporal region. Coming to anti-VGKC related encephalitis, limbic encephalitis, it is also predominantly limbic encephalitis with anti-LGI1 and Caspar-2 antibodies. Almost 30% cases are paraneoplastic. The rest of the 70% cases need not be, we need not find an underlying neoplasm. And 56 to 92% cases can have seizures. And higher when the patient is having anti-LGI1 antibody titers. And most of 90% of cases are present with facial-brachial dystonic seizures. And various study and reports have observed the following findings like slow background activity that is consistent with an encephalopathy, as well as diffuse background slowing, along with facial-brachial dystonic seizures. And this is a case of 67-year-old male with history of facial-brachial dystonic seizures with mild recent memory complaints. On example, his MMSE was 29/30. 1 point was lost in recall. And MRI brain showed bulky amygdala bilaterally, and his serum LGA1 antibodies were moderately positive. Here the EEG read in bipolar montage showed left temporal slowing, right temporal slowing. This was the video showing faciobrachial dystonic seizures. Patient is lying awake in bed. There's a sudden left upper limb jerks that was notable. Correspondingly, this was the corresponding EEG in the bipolar montage, which was marked by artifacts, and no definite correlates were found in any of his jerks. This was the seizure onset and the average montage. Coming to EEG in seronegative autoimmune encephalitis, almost 50% of cases of seronegative autoimmune encephalitis also can show seronegative autoimmune encephalitis can also show EEG changes like poor background reactivity, slowing, as well as lateralized periodic discharges. Coming to EEG in infectious encephalitis, similar findings like lateralized periodic discharges characteristic in HSV encephalitis can be seen in infectious encephalitis. International Encephalitis Consortium recommendation has included EEG as a minor diagnostic criteria for encephalitis or encephalopathy or of presumed infective or autoimmune cause. HSV encephalitis, HSV1 has predilection for the temporal lobes and frontotemporal region, and findings include polymorphic delta involving the affected temporal lobe. There can be focal sharps and seizures and status epilepticus also, lateralized periodic discharges, and absent reactivity to auditory noxious stimuli, which are poor prognostic markers in HSV encephalitis. Coming to a case, this is a 42-year-old female who presented with fever with upper respiratory tract infection 4 weeks back with new onset seizures of left hemispheric extratemporal semiology. There were no cognitive or behavioral disturbances in the patient, and MRI showed bilateral mesial temporal T2 flare hyperintensities and bulky hippocampi, and CSF HSV PCR was positive. This was the age of the patient. There was predominantly there's periodic discharges in the fronto-central regions, as well as there was slowing in the frontal as well as temporal regions. These are left there are left hemispheric lateralized periodic discharges, predominantly fronto-centro-temporal regions, and there is background slowing also. Same in average montage. The arboviral infections like dengue can also show EEG slowing when when they present with dengue encephalitis. Measles in children can have EEG manifestations even without CNS involvement. This was an EEG showing delta slowing in a patient with dengue on the 5th day of illness who presented with altered sensory. Coming to EEG in dementia. Role of EEG in dementia to rule out CJD. which can help in prognosticate, which helps us in prognostication as well as telling the severity of the disease. To rule out NCAC or electrographic seizures when patient present with low consciousness levels. And in dementia, EEG, quantitative EEGs and event-related potentials can be used as biomarkers for mild MCA as well as AD. And to rule out, it also helps to rule out metabolic encephalopathy when patient presents with altered consciousness. And the prototype CJD, CJD in early stages can show diffuse slowing or frontal intermittent rhythmic delta activity. In the mid to late stages, they can have the characteristic generalized periodic sharp wave complexes, which are high voltage triphasic or diphasic sharp waves that repeat at irregular interval. And in the later stages, patient can go into coma traces or even alpha coma. And seizures are present in less than 15% of the patients. Coming to a case, 54-year-old female, housewife, history of rapid cognitive decline over past 3 months with involuntary jerky movement of limbs and bedbound status. And her imaging showed cortical ribbon pattern. This was the EEG that was read in bipolar montage with the sensitivity of 20 microvolts per millimeter. And they show periodic discharges of atypical triphasic morphology seen bilaterally. These are short interval periodic discharges. Coming at a frequency of 1 to 2 hertz per 1 to 2 hertz. This is the same read in average montage. Less than 4 seconds. Less than 4 seconds. So here it is a little asymmetric. So here the patient is having slow background activity, poor reactivity, bilateral periodic discharges, asymmetric ones, coming at a frequency of 1 to 2 hertz. So these are short interval periodic discharges in a case of CJD. Coming to SSP, subacute sclerosing panencephalitis. EEG is included in Duggan's criteria for SSP diagnosis, and the typical classic EEG finding described is a periodic complex. Are periodic complexes consisting of bilaterally symmetric and synchronous high voltage burst of polyphasic stereotype delta waves. And in the later stages, patient can have a random dysrhythmic slowing, and later in terminal stages, patient can go in for low amplitude waveforms. So here we can see bursts of low voltage activity, bilaterally symmetrical with intermittent sharp waves. Polyphasics and sharp waves, that is bilaterally symmetrical. Bursts coming with interval more than 4 seconds. So these are long interval periodic discharges with periodic complexes in a case of SSP. And background activity here, background is also slow with poor reactivity. There are 30 millimeters paper speed. Sweep speed. No. Myoclonic jerks, but this is just after the. non-time lapse with the periodic complex. And EEG is usually normal in early Alzheimer's disease. In later stages, they can have reduction in background activity and slowing, most commonly involving left temporal region in majority of studies. And 2.9% cases can have rare FIRDA. And if there is epileptic activity in EEG in a patient with AD, it is a poor prognostic factor and is a risk factor for seizure, especially if patient has greater cognitive decline at younger age and has a history of antipsychotic drug. And quantitative EEG slowing can predict cognitive and functional decline in AD. This was a patient in with Alzheimer's disease. This EEG read in bipolar montage. This was a probable patient was in drowsy mood. Patient was drowsy, and it showed left temporal anterior left temporal spikes. Same read in average montage, and there is a left temporal slowing also, but patient was drowsy, probably sleep, poor background activity. In dementia with Lewy bodies, also there can be decreased reactivity of background activity. A DLB can have in 33% cases are characteristic of FIRDA. In case of FTD, the EEG abnormalities are not as frequent as AD. In very late stages, they may show some frontotemporal slowing. Coming to EEG in neurodevelopmental disorders, role of EEG in neurodevelopmental disorders, they can detect underlying electrographic seizures or ESCS pattern in rare individuals. And from the EEG, some typical patterns can give a clue to underlying genetic abnormalities if typical patterns are seen. And EEG is also used in diagnostic and research insights. In autism spectrum disorders, resting EEG studies have shown, various studies, 5 to 57% of individuals with autism spectrum disorder showing epileptiform discharges at rest, typically without presence of clinical seizures. The studies vary from 5 to 57%, but on average, 1/3 of the people with autism spectrum disorders may have epileptiform abnormalities without the presence of clinical seizures. And subclinical epilepsy overlaps between the disorders, and EEG findings that that it includes centrotemporal spikes, ESCS pattern, which is very rare. Here is a case of a 6-year-old boy who presented with language delay and reduced peer play, had ADHD and autistic traits. He was on speech, behavioral, and occupational therapy, but with that, there was no improvement with therapy. So, upon admission, patient was an EEG was taken, which showed centroparatal temporal spikes with frontal positivity. This was patient. This was recorded in. This was an EEG recorded in sleep record in bipolar montage, showing centroparatal spikes with frontal positivity. Frontal positives. The patient has well preserved spindle architecture, but the record was it was amounting to ECS. The whole record for patient. Jesus.
Maybe record. I think that will be better.
Sleep.
these are all that events. Just that's the diagnostic.
We will try. Yes. Clinical seizures, we will give trials. Trial, trial given. Sir, if clinical seizures are not there, but
Findings the saying it's not because diagnosis, right? It's a decline and the cognitive skills decline from baseline. And it's when we investigate these two. The CET at least should not be taken
Yeah.
in validations. You have a different history of decline, so it is better kind of might have to permanent that in a clinical context, and of course, considering etiologies that have been released, there are underlying genetic problems that are getting investigated. These discharge stadium aspects of the underlying etiology may not be amounting to an epilepsy. So,
so EEG in Rett syndrome. Rett syndrome, based on age as well as they can have natural history of various stages, and EEG can be different in all these stages. Initial early stages, there can be background slowing. Later, when there is a rapid destructive stage, patient can have centrotemporal spikes or sharp waves. Atypical spike and wave discharges may be seen. Later, there can be high voltage delta and spike waves, multifocal spikes, spike waves, and rhythmic bursts of central delta activity may be seen. In later stages, there can be marked background slowing with frontocentral rhythmic delta, and there can be multifocal spike waves as well as generalized slow spike waves in sleep. And epileptiform activity may be seen in the later stages. This was a 66-year-old female with history of global developmental delay, with intellectual disability and cognitive and behavioral disturbances, who had a pathogenic variant in MECP2. This was the EEG read in sleep in bipolar montage with a sensitivity of 15 microvolts per minute, where it showed centroparietal as well as temporal spikes, centrotemporal spikes. The same read in average. But this sleep structures were seen, spindle were seen bilaterally, well formed. Coming to Angelman syndrome. Angelman syndrome, there has a basic GABA neurotransmission defect, which is linked to the pathogenesis. And the children can have various mutational abnormalities. With micro deletions like 15q11 to q13 deletions show more severe neurological picture, whereas if it is uniparental disomy or imprinting abnormalities have milder neurological phenotype, and they can have different EEG findings also. And EEG findings described in Angelman syndrome include posterior background slowing. There can be intermittent rhythmic delta activity, and there can be classical notched delta waves with that is delta waves that are superimposed by spikes, predominantly seen in frontal or occipital regions. And there can be rhythmic theta activity similar to rhythmic delta activity, as well as IEDs. This was a 4-year-old girl with who presented with features of genetic mutation, Angelman-like phenotype, and this is a record in the sleep showing sorry, this is a background. This is an EEG read in awake state with bipolar montage of montage with a sensitivity of 10 microvolts per minute. There is intermittent rhythmic delta activity with notching, predominantly seen in the occipital regions. Bilateral occipitals with the notching. Front.
These two the are both for lifelong discipline and may not have very good correlate coming. So,
The range in coma.
I think as well as organs, and only what was covered in this particular and semesters that's metabolic is metabolic instabilities you have the acquired process of detoxing anxious intermediate as metabolic instability. Metabolic you have not covered the childhood metabolic disorders.
EEG in coma.
But
EEG in coma, hypoxic and hypoxic.
that's all. And then you have EG acute conditions. Then you have product with what EG problems. It's radiology sites which as well as developmental etiologies in this policy. And etiologies is big conditions, that's very simple, disciplines. In some cases, like you progress with encephalopathies again, there is nothing further, no one takes up possibly is there. Really, I got this is think that Steve has for the mental disorders, the internal pattern which you have shown is not that at all. Other than the moving patterns. The EEG might suggest that epileptic is patient does not have experience. These might be here. You can have multiple weak patterns, you can have the place patterns. Those are consequences of the underlying. That might suggest that I should investigate these patients with a genetic test or next generation sequence. You know, can like other thing, but on the other hand, our patient with the recent lack of which is earlier onset, that's stage in the years, more fibrotic rates, reduced comprehension, reduced total comprehension. The EEG might tell you that it's severe developmental activity, it's like your application. In those conditions, you will monitor the child next. The child have very good writing skills and reading skills and all. So when you declare the matter, just EEG. Data service. And in certain given scenarios, you can using the EEG as a part of it. And the clinical diagnosis amounts to this condition of EE, this spectral activation, it's a case, CSWs, and atypical for anti-epilepsy. The three things come under the EE with spectral activation. And the acute condition, EEG might be used for giving you a supporting the diagnosis of metabolic ignorance. Metabolic toxic, it is called new system, and EEG just gives a wonder. And of course, it will help you to do not all converse status. So, main indication practical scenarios, we do not all converse status and support your clinical. Apart from that, it is for specific one for EEG saying that this is signature of this action. With that front, this effectively. Similarly, as you were showing the housing detail, it's like that was more in distance, the patient with renal dysfunction, whether students, the following treatment of urinary tract should suspect fungal persistence. Okay. Similarly, for patients on chemotherapies, now these are the patient connected with unexplained coma, EGs, EG sensitive mandatories. Again, to look at fungal persistence. Then you get the patient has coma with generalized periodic symptoms. That is consequent by and of course, of beta and beta coma. And beta coma is specifically toxic.
Toxic.
And it will reduce forms. And have these periodic these scenarios. That just happen. Support your clinical increase. And we will flag the investigation as well for these clear. It's it has more towards the supporting role of EEG rather than diagnosis. That's been noted.
Thank you all. We are winding up this session.